Helen Wilkinson is a senior BMS in blood transfusion at the Royal Hallamshire Hospital, which is part of the Sheffield Teaching Hospital NHS Foundation Trust. She's got over 15 years of experience. 10 of those are working as a senior BMS in blood transfusion. Welcome, Helen. Over to you.
Thank you very much, Selma. So as just been mentioned, I'm a senior biomedical scientist in transfusion at Sheffield Teaching Hospitals with a little bit of experience there. To give you a bit of a background as to where I work, Sheffield Teaching Hospitals is split into two major trusts. We've got the Royal Hallamshire Hospital, which is where I'm based, and we're quite a big user of blood products. The haematology patients use most of that, and that is for the transplant patients, the sickle cell patients, thalassemia patients. We also have we do the antenatal obstetric and gynecology work. So we do all the antenatal samples, so all from the booking bloods, group and screens. We do the cell-free fetal DNA testing to determine of those RHD negative mothers which are predicted to have RHD positive babies. And then following on from that, we also do the FMH testing, mostly by flow cytometry. And we do a lot of neonatal testing as well. And the Sheffield Children's Hospital is close by to us, as well as issuing blood products for babies at our hospital. If they need surgery, we often provide blood and blood products for the Children's Hospital if the baby goes for surgery there and then comes back to us. And we have quite a lot of neurology patients, as well as the regular sort of theatres that are ongoing in the background. So we use quite a lot of blood and blood products. The other major site is the Northern General Hospital, and that is based at the other side of the city. This is actually a major trauma centre and has been for a few years now with its own helipad. So they're used to dealing with unknown casualties and MTPs. They have also a lot of cardiac patients and renal transplants. So between the two of us, we do use quite a lot of blood and blood products. But we also issue blood to two private hospitals that are nearby, and to Western Park Hospital as well, which is a cancer hospital. So we are quite a busy department most of the time. To the Hallamshire building is the Jessup wing, and this is our dedicated maternity unit. It's got a neonatal intensive care and special care wards for babies, and often we will have neonates arrive from other hospitals because we've got so many wards, so patients transferred from out of area. And around 7,000 babies are born here each year. Now, in terms of logistics, the blood transfusion laboratory is actually based at the Hallamshire Hospital, and it's connected to the Jessup wing via a corridor, and it's approximately a 5-minute walk between the two. And so because of this, we have a blood fridge on site at the Jessup wing in case of an emergency. And so we do stock in there 2 units of adult O-negative red cells and 2 units of neonatal O-negative red cells, just in case of an emergency. And we have approximately 1 massive obstetric hemorrhage a month. So we're quite used to dealing with emergency situations and the logistics. But I mean, to put it into sort of context, back in 2020, when we looked at the stats, we only used 3 adult units of emergency O-neg at the Jessup wing and 5 neonatal O-neg units during that entire 12 months. So although we're high users of blood products, I think because we do a lot of the antenatal testing, we are well aware of a lot of patients being able to be electronic issue for blood, so they don't have to use the emergency O-neg, or if there's any kind of complex antibodies, we can preempt these kind of patients and have blood on standby ready. So in terms of using the appropriate blood products, we don't use a lot of O-negative blood cells for these emergencies. We are actually also an abnormal placenta unit. So this means we do sometimes see the abnormal cases. We do get them transferred to us from, like, say, regional other hospitals. One of the other reasons being because we use cell salvage quite a lot. And blood bank is kind of prepared for these situations. So the case I'm going to talk to you about today is a case of placenta percreta. So during a normal delivery of a baby, the baby is born, and then the placenta detaches cleanly from the uterus and is born shortly after the baby. What can happen in these complex cases is that the placenta can grow, either attach or grow through the wall of the uterus. And this is often through old scar tissue. So, for example, an old cesarean section scar, something like that. And it means that the placenta can't detach cleanly. So there can be a vascular involvement there. And there are 3 different grades to this complication: accreta, increta, and percreta. So as you can see from the diagrams, placenta accreta is when it attaches, but it's still within the uterus. Increta, it started to invade, and then percreta, which is kind of the most serious of the 3, is when it actually the placenta actually invades through the wall of the uterus, and it can actually attach to other organs in the body, commonly the bladder. And so this means that the placenta is then unable to detach cleanly, and it can cause major hemorrhage in a patient and can be quite life-threatening. So for this particular reason, the majority of placenta percreta patients, they have it identified quite early on in a scan, and they often will go for a cesarean section, and then they'll have a hysterectomy performed at the same time to minimise that blood loss and control it, to keep the patient out of harm. So this particular patient, she's a 34-year-old lady with 2 previous cesarean sections, so she had some scar tissue there. And at 20 weeks pregnant, she was transferred to the Jessup Hospital, and it was discovered that not only did she have placenta percreta that had invaded and was now attaching to the bladder, she also had placenta previa major, which is where the placenta is covering the birth canal. So again, it's two quite big complications there for a pregnant lady. At 29 weeks, they did another scan. At this point, they noticed that there was also a large varicose vein and varices around the uterus, which are sort of enlarged veins, adding to the complexity of this delivery. And obviously, you don't want either of these to rupture before the baby's ready to be born. And the patient then became unwell. And at 30 weeks, they did another ultrasound. And at this point, unfortunately, they found the placenta had also invaded into the pelvis and the iliac arteries, which are the arteries that kind of run down into your thighs from your pelvis. So obviously, anything invading an artery indicates kind of a very vascular procedure. And at this point, also, the patient was suffering from heart failure. Now, it was insinuated that it could be that the amount of blood needed around the uterus was actually meaning that the patient couldn't be getting enough blood up to her heart. So the decision was made at this point by the team that they needed to get this baby out as soon as possible to try and save this pregnancy. So we had a plan. Well, the obstetric team had a plan, and then we found out about the plan. So there was expected to be a massive blood loss that was kind of going to be inevitable. So they planned to do a cesarean section with a complete hysterectomy the following day. They prepared the 2-cell salvage machines, which we frequently use at the Jessup Wing for complex pregnancies. And they also had the thromboelastography machine ready, the TEG machine, which obviously can help indicate which blood products are needed rather than just ordering like a MOH pack every time. And then preoperatively, the patient, hemoglobin was 117, it's quite healthy. Platelets were healthy at 328, and all her clotting was within normal range. The patient, we'd typed a couple of times, and she was group OD positive, and she had a negative antibody screen. From the lab's perspective, we could electronic issue blood without any complications, which was helpful. And so the night before, 6 units of red blood cells were prepared and taken down to the Jessup Wing Theatre. And it was decided that although this was going to be complex, they didn't want any pre-thawed plasma. So at the Hallamshire Hospital, we don't have pre-thawed plasma, but at the Northern General, with their trauma packs, they often have pre-thawed plasma every day in case those MTP patients come in. So again, just to put it into perspective, so our local MOH protocol, because of the TEG machine down in theatre, is to issue 4 groups of red cells group-specific and electronic issue in most of the cases, and 3 bags of FFP. So that initial phone call you get of, we've got an MOH, that's the first thing that we do. And then platelets and cryo or fibrinogen concentrates can be ordered as and when needed. And like I say, we are a high blood user, and on site on any given day, we've got at least 30 units of OD positive red cells. And as stock, we also have 2 groups of A positive radiated platelets and 2 groups of O positive radiated platelets. Now, these are purely for our MOH patients, which, granted, they don't need irradiated products, but because we don't have many MOHs, we have irradiated products on standby because hematology patients can then use them as they're nearing their expiry date. We also have 4 adult doses of every group of FFP and 3 adult doses of cryo in every group. We also have a huge freezer full of octoplas. And although it's issued by pharmacy, there are fibrinogen concentrates and tranexamic acid. So in terms of this patient coming to us, we were in the best position to provide all products that she should need. So on the day of delivery, at 8:30, a healthy baby girl was delivered by cesarean section. And what I hope you can see here on the right-hand side is I've put together a little chart of the products and things that were ordered. So at 11:42, we received our first request for an MOH pack. So we got defrosted the FFP, and 6 units of red cells were issued. That's an additional 6 to the first 6 already ready. So as you can see from the timescale there, over the next 6 hours, there was a lot of frequent and rapid blood products required. You can see there that it wasn't just a standard MOH pack given. Things were ordered as needed. You can see the blood groups, the majority of which were Group O given to this patient. We did have to switch to Group A a few times, which I'll come to in a minute. And then also blood results. So they were frequently monitoring this patient throughout as she started to bleed. So you can see there hemoglobin at the beginning was quite okay, then a hemoglobin dropped. So these were done by either a full blood count or done by point of care testing, like a blood gas. And then you can tell when the phone calls came in. So for 6 hours, that is an awful lot of work for the laboratory staff to be doing. All the products were requested by phone and they were fully documented, and everything was collected by the Jessup Wing staff. So as I was saying, the Jessup Wing is about a 5-minute walk away. So the staff were running across the corridor to come and get the blood products, and then they were running back again as well. And then at 5:01, we got the last request for red blood cells. And then unfortunately, shortly after this, the obstetric team decided that there was no possible way that they were going to save this patient's life. The blood loss was far too extensive. They tried to control it through all sorts of means with balloons and all sorts of techniques that they had. But unfortunately, they made the decision to bring the patient out of her anaesthetic. She came out of anaesthetic, she met her baby daughter, and then a few hours later, unfortunately, she passed away. And at this point, when the lab staff found out, you could see that we all kind of visibly sagged. It was a very emotional day. We'd all put an awful lot of effort into this and time, and then to not get the outcome that you hoped for was quite saddening. And that's another point I'll come to in a little bit. So in terms of the products used, just to put it into perspective, and I did that little chart, but in total, this patient used 5 litres of cell salvage, over 80 units of red blood cells, 13 units of platelets, 5 doses of FFP, 3 doses of cryo, and a litre of octoplas. So that's an awful lot of products on one patient, and these were kind of ordered as and when needed. The group-specific OD positive blood was used throughout, so we didn't use any O-negative blood. And group-specific OD positive platelets were mainly used. There was a couple of occasions we had to use our group A D positive platelets while we went for a restock. And fibrinogen concentrates ran out. They used that much of them, so we had to switch to cryoprecipitate at that point. And at one point, we also ran out of FFP, so we had to switch to octoplas while we had a restock of FFP. But they did use tranexamic acid. like I said, 2-cell salvage machines, and due to the use of the TEG machine and blood gas readings, this meant that the products were only ordered when the patient's stability required it. So that was good use in terms of use of products. Like I said, they were only ordered actually when the patient needed it. So what did the lab staff actually have to do that day? Well, when the first call came in, we all knew this case was going on. I don't think any of us realised the extent of attention that it would need. But the staff actually naturally divided into red cells, platelets and frozen products, which was very handy. It was a very natural occurrence that. We did have to draft in extra staff from other areas because although we were focusing on this particular patient, we still had a hospital full of patients. We still had day ward patients, theatre patients, lots of the people that needed products. We still had the routine bank delivery to book in. So we noticed early on we needed to get extra staff in, so they came in to help with the routine work. And we had to devise a crude sign-out sheet. So obviously products are signed out from the blood laboratory and taken over to the Jessup wing. But the staff didn't have time because they had that walk to the Jessup wing. We had to devise like a crude sign-out sheet. So you can see here on the right-hand side, we've got the sticky label from the actual unit to reduce transcription error, what the product actually was, the expiry date, and then the time taken from the fridge. And then what we did then is we've got some dedicated MLA staff that work in blood bank, and they helped us sign up the products retrospectively. So they were doing a lot of the paperwork so that the support staff from the Jessup wing could go straight back to the patient. And that was really important because we didn't want there to be any delay in blood products. And for those that have had a look at the SHOT report recently, I know that delay in blood products is one of their big learning points this year. So that we were keen to make sure that when the staff arrived from Jessup wing, they could go straight away with the products and we could still keep the traceability. On top of all this, we had to manually reorder products to fill the fridge and the freezers back up, and we had to order taxis to collect blood products. I mean, at this point in time, the NHS BT for us was based at Sheffield at Longley Lane, which is next to the Northern General Hospital. It's now moved since to Barnsley, but at the time it was only 3 miles away, so ordering products was quite a quick process for us. We also obviously had to take the frequent phone calls, not just from the staff dealing with obstetric hemorrhage, but also from the rest of the hospital. And we also had to issue products accurately and carefully. Anybody that's been in any kind of these trauma situations knows that it's so easy to mix your labels up, get your FFP and your cryo mixed up. So staying focused and issuing the correct products was also vital. So for that whole day, all the staff working flat out, but keeping calm and composed. And knowing our timescales is important. So if somebody did phone and ask for FFP cryo, we knew exactly how long it would be from how long it was going to take to defrost, things like that. Post-analysis the following day, we had a big think about what we could have done. Although we did everything that we could in the laboratory, I'm not sure that that would have made a difference to this particular patient's outcome, but there's still points that you can take away from any kind of situation like this, learning points, what worked well, what didn't work so well, what can we improve on. So the positives first. Well, the communication was excellent. So the theatre staff speaking to the lab staff, they were very clear, concise, and included the clinical details of the patient. So that meant that the lab staff were fully aware of exactly what was going on. There was no rumours, there was no flapping about. We knew exactly what was going on and what was needed. And at some points we did actually preempt that this was an ongoing case. We could preempt the next lot to be defrosted or the next red cells to be issued. And some of that does come with experience. This also meant that the lab staff, when speaking to the theatre staff, could give accurate times for product availability. So like I say, we knew how long FFP was going to take to defrost, or if we went for a delivery, how long it would be before the delivery was here. So we will all be able to communicate really efficiently. And this gave confidence to the theatre staff. They knew then that they could rely upon us. If they phoned us, we would have it in hand. One of the big things I think people forget as well is actually communication with your local NHS BT. When you run out of products, it's them that need to get you some more products. So we spoke to them very early on and explained that we had this extremely large obstetric hemorrhage going on, and apologise. And if we've ordered some blood products and we haven't phoned you to tell you put the order in, it's not a mistake. We do want those extra 20 units of red cells. So they were really grateful of that communication as well. So they knew what was going on. The teamwork was really good on both sides, from the obstetric team and the lab team. It was efficient, there's no panic, no confusion, clear communication. The work was prioritised amazingly well. So even the routine work that was happening in the background, there was no delays in transfusion for anybody there or anything like that. And the extra staff that helped just came in and kind of took over. So that was really good as well. And traceability wastage. So we had 100% traceability of all blood products, which I thought was absolutely amazing in such a situation. There was only 4 units of red cells wasted, and that's purely because they were left in the theatre where the patient had been, and they forgot to bring them back in time. We wasted 3 units of cryo and 5 units of octoplas. That's purely because they were no longer needed, and between them expiring, we didn't have another patient that could have used them. So in terms of blood products and traceability, I thought that was excellent. But what could we improve? There's always something you can improve on. Prior warning would have been helpful. So although I said the patient was at Jessup Wing, she actually wasn't due for surgery there. She was due for surgery at a different trust. But as her health quickly deteriorated, she didn't have time to put the initial plan she had in place. So that's why she was transferred to Sheffield. So our blood bank didn't know anything about this patient until about 24 hours beforehand. And looking back now, I think we could have stocked more Group O red cells. We could have prepared some pre-thawed plasma. We could have had additional platelets on standby, and definitely additional fibrinogen concentrates. Those kind of things, if we'd have known quite how big this case was going to be, might have helped the lab staff and the patient. And stock management. So this was an interesting point. We use the vendor managed inventories, the VMI. So it checks our stock levels every 30 minutes and sends our routine deliveries out and tops everything up for us, which is amazing. And we've also got our local emergency levels. And if we hit these emergency levels, then obviously NHS BT gets the trigger. They phone us at the lab and say, you've hit your trigger for this blood group. Do you want it replaced? And we can say yes or no. What we actually found here is that we triggered the emergency levels multiple times very quickly on our red cells, but we couldn't wait, say, for another 20, 15 minutes for the NHS BT to get that signal to phone us to ask if we wanted the blood products. So we were actually having to manually order blood via OBOS before the VMI was triggered. So this added a little bit of extra work onto the lab staff, obviously having to order the appropriate blood products that we needed. So that was an extra step. And then also we had to send a taxi driver out to then collect the blood products. And that's something we do online as well. And we also realised there was no emergency trigger for plasma products. So at one point we did actually run out of Group O FFP. And we had to use the Group A while we actually manually order more FFP. And like I say, at this point, NHS BT was in Sheffield, only 3 miles away. And now with it being in balance, it takes a little bit longer for us to get blue light products. I think if this case was to happen again, we would definitely order in more blood products beforehand. And also we would probably utilise the Northern General Hospital being quite close and probably pinch some of their blood as well, to be honest. We do transfer stock between the trusts quite frequently, so that wouldn't be an issue. We did manage to upset the taxi driver though, unfortunately. We didn't think this one through. So we do have a local taxi, we use the local taxi firm, we have an account with them, and they will drop off samples to NHS BT and collect non-urgent blood products for us. They're not used for emergencies or for sort of, we wouldn't send them to collect some frozen blood products or something like that, but it's the non-urgent things. But when we've ordered 20 to 30 units of red blood cells and a restock of FFP and a restock of platelets, and then you get those big NHS BT boxes, the taxi driver had to actually borrow a wheelchair from downstairs in the trust to actually bring the products up. And at that point, we realised early on in the day, we had to use the NHS BT drivers. They've got the vans, they've got the know-how. So yeah, that was definitely a learning point for us. So the documentation, that was something we could improve on. So although traceability was excellent, our makeshift piece of paper with sticky labels on wasn't the most, well, it was accurate, but it wasn't the most robust. So what we've actually done instead with our LIMS system is we've improved the way of retrospectively signing up blood products. So now we can print out a document that every time, just for urgent cases, every time you issue a batch of products, we can print all the demographics out, and then we can just write at the bottom of the piece of paper what time they were signed out, and then the MLA staff can match the patient details, the unit details, expiry dates, what the product is, and the time signed out, and sign it out for us. So that was definitely a plus as well. And obviously, after this, we did actually receive thanks from the obstetric team, and this isn't something we always get. So the lab being aware that the obstetric team did appreciate everything that we'd done that day was actually quite a boost to everybody, because a lot of people felt quite down about this experience for quite a number of days, and it can be quite a traumatic experience for lab staff. And I don't think this is something that's ever really covered for biomedical scientists, that just because we don't see the patient physically, we're not there at the front, doesn't mean to say that we don't actually care. We kind of put a face to a name without it, and we do get really upset sometimes if things don't go right. So the staff needed to process what had happened, and we did have some sort of mini debriefs about this. We did chat to staff afterwards. We kind of had to digest the whole situation. But for anybody just new starting out on their biomedical science career, if something like this does happen, it is okay to feel upset about it. It is okay to think about what happened and work from that, because it's not all brilliant sometimes in our jobs. So that's kind of one of the takeaway messages I hope you'll get from this. And that's the end of my presentation. So I hope that might be of interest to some of you. And if anybody's got any other tips of how to go forward or improve their situations, I'm happy to hear any suggestions. And thank you for listening.
Thanks, Helen, for your excellent talk. We've just got one quick question in the chat, and it's a comment and a question. It says, "I'm very sad about the patient. Would whole blood have helped in this type of major hemorrhage?"
I'm not sure in this particular case it would have done. I think because they've got the TEG machine there and they can manage the coagulopathy of the patient, they were ordering the products as and when needed. I think for whole blood products, that's more kind of a ground level trauma when you suddenly come across somebody. So getting the whole blood in might be more beneficial then. But I think this was so well organised, as well as it could have been. They were very much in control of what the patient needed. I'm not sure whole blood would have been much of a benefit on this case.
Thank you. So there's some other comments. Very interesting case. Thank you. Very good teamwork. And somebody also asked, would a hemobank for quick release of emergency products have helped at theatres?
Yeah, so we don't have a blood tracking system at the teaching hospital. And I think something like quick release, blood on standby, group specific blood made more available to a specific patient could have been helpful. Although I have to say, I don't think we had any delay, because as the day went on, we were preempting the fact that they'd probably need more red cells. So by the time the obstetric team phoned and asked for another 6 units of red cells, we'd already have them in the fridge ready. So all the staff needed to do was to come across and collect it. So they were collecting blood before they needed it in the obstetrics, and we were issuing blood before they'd asked for it, kind of thing. We kind of were one step ahead with them at some points. So they never were without blood in theatre. They always had blood in their theatre waiting for them.
Thanks, Helen. We've got another question in the chat. It's, let me just find out where we are. Still a few comments and it's just disappeared. The VMI system is new to me. Is this from your limb supplier or does it come from NHSBT?
This is NHSBT. So we use the online blood ordering service, OBOS. So it's like online shopping for blood products. And they have access to our blood stocks via our limbs, and they can monitor our blood stocks. So we have a delivery in the morning and a delivery in the afternoon of routine products, and so routine products for us are group O and A positive. We have irradiated stock as well of O and A, irradiated blood products, those kind of things, and we set the local limits of what our stock needs to be, and this can be adjusted. But yeah, so the VMI checks our levels, and then at a certain cut-off time, it says, right, you need another 10 units of O-pos red cells. So then at the next routine delivery, those 10 O-pos red cells occur. It's not for all specialist products. We still have to order in sort of antigen negative blood. We still have to order in neonatal products. But for the bulk of our stock ordering, yeah, it sort of arrives without us even having to lift a finger, which is quite good.
Thank you. Yeah, somebody said fair point, tag is very effective. May I just remind you guys, if you do want to speak, please raise your hand and we'll ask you to speak. Otherwise it gets very difficult to read all the comments. Somebody says, I'm an emotional wreck. Well done, everyone. I think it's under-recognized that the lab staff do get attached to the patients, both hemorrhages and long-term patients. And I definitely agree with that.
Definitely.
Somebody, Helen Morris, would you like to come in, speak?
Hello, yes, that's me. Thank you. Thank you for that presentation. Very interesting and obviously good teamwork, as everyone's saying. It was me that asked the question about the BMI system. So we also use OBOS. I think most people do nowadays. So it sounds as if it does come through your limb. Did you say it does talk to your limbs to see your levels?
It does, yes. Can't tell you exactly how. That's kind of behind the background, but yeah, it does go through our limb system. So we use Apex.
That's my next question. Which limb do you use?
Yeah, we use Apex, and it queries our blood stocks every half an hour, and then can
half an hour. Good.
Yeah.
So we're just going through a limbs. What's the word? Tender process. So it's something I hadn't heard of it. So it's something I hope we're going to write into the limbs tender. So thank you for that. Thank you.
Great, thanks. And then somebody's asking, why wasn't baby delivered earlier? Great presentation, by the way. Thank you.
I mean, that's probably a question for the obstetric team. I can only assume that at one point the patient was quite stable. They were regularly doing ultrasounds on this patient. So, and this is information I'm getting after the event. So we weren't kept in the loop, obviously, during this pregnancy. It was only when the patient's health deteriorated and she started with heart failure that they decided that that's when the baby was going to be born. And at 30 weeks, that's not the earliest delivery we've seen. So I think they were trying to let the baby be in its most natural environment for as long as possible before delivering.
Thanks, Helen. We've got another question in the chat. Did they perform the hysterectomy?
Yes, they did. So the hysterectomy was performed not shortly after the baby girl was born. But I think because the placenta was then attached to the bladder and then it was attached to parts of the pelvis and it actually grown into the arteries in the pelvis. I do know that they use things called some sort of balloon where you can put it into the artery to try and inflate it, to try and stem the blood flow. I mean, the obstetric team and the amount of the urologists that were involved, the obstetric team involved, the number of surgeons involved there that tried everything that they could. I just don't think they could have done any more for that patient. And the patient was fully aware of the situation before she went under anaesthetic. She had consented to this surgery, so she knew full well that the risks involved in this. That was one of the things that the obstetric team did relay to the lab staff actually afterwards in a bit of a debrief. They did say that, the patient knew this might happen, but she still knew that that was the only kind of way forward for her.
Sure. We've got two more questions which are somewhat linked. The first one is, did the patient go into DIC and what was the clotting screen like after the baby was delivered?
So there wasn't an initial clotting screen done initially after the baby was born, and there's never the mention of DIC. That wasn't a clinical term that they used for us. So I'm not saying she didn't go into DIC, but there wasn't enough samples sent for clotting screens to figure out if that actually was what happened to the patient. So I know the fibrinogen dropped quite considerably. And at that point, we ended up issuing cryoprecipitate as well. But yeah, I think just the blood loss itself was more what they were focusing on to try and stem that before they could then evaluate what could happen next.
Great, thank you. Shabana, did you want to come in?
Yeah, hi. What I wanted to know was, you mentioned that there were two previous C-sections. What was the kind of history behind those? Were there previous complications with this patient?
I couldn't find any evidence. So again, it was quite difficult. But this patient was outside of our area. She was kind of dual care, so I didn't have full access to the patient notes. There was no mention of her having previous complications. So whether or not they were just routine elective C-sections, but no, there was no sort of history of placenta accreta or percreta. But yeah, unfortunately, we didn't have full access to her historical notes, just the ones from the Sheffield teaching hospitals.
Thanks. I was just going to ask my colleague Deepa Taka, who was the customer service manager in Colindale. Would you like to give us a little sort of background on what BMI is, because few people are interested?
Hi, Selma. Thank you. Yeah, I don't know too much about BMI, but from what I do know is similar to what Helen's just already described, which is we use an algorithm to make sure that we top up a certain level of components based on what your regular use is. So if there is anybody out there who is interested in BMI, if you drop either Selma or Danny your details, we can forward it on to our experts and they can check whether your LIMS has the minimum requirements so that our LIMS can speak to each other and that you can have that service on your site if it's something that you wish to have. I mean, you still have the freedom to manually order units outside of that algorithm should you sort of in an emergency situation like this need extra units. And so there is flexibility there. While I'm here, I actually had a question for Helen. Did you mention that your blood bank fridge was 5 minutes away from the ward? Is that what you said earlier on?
Yeah, so we have an issue. The laboratory is based 5 minutes away from Jessup Wing. So Jessup Wing do have their own blood fridge, but obviously they have to manually sign everything in. But yeah, there's a fridge the issue fridge at the blood bank laboratory, and there's a blood fridge at Jessup Wing. But the walk between the two is 5 minutes. Yeah,
because I was thinking whether having sort of quicker access would have influenced any changes, or maybe having a transport bag or a box with sort of units in there ready to take out to save that 5 minute walk.
I think the 5 minute walk at some point, although it was done quickly, was actually to replenish the Jessup Wing fridge. So the obstetric team was so on the ball that they knew they were getting low on the blood available at the Jessup Wing fridge, so they'd ask for more units from us. So actually they weren't ever out of blood. I mean, for us, what would have been ideal is kind of remote issue from a blood tracking service system that would have been really good.
Yeah.
But yeah, the 5 minute walk, in some MOHs it is literally an emergency because it's a surprise. But I think because this one was more planned, they were kind of restocking their Jessup Wing fridge with blood units that we'd issued, ready for the use of them, so they never kind of ran out.
Yeah, because you can imagine sort of in hospitals, the corridors seem endless, don't they? Especially in an emergency situation.
Yeah.
Thank you. That was all from me.
Thanks, Deepa.
We've got another question regarding the products issued. And the question is, were all the blood components ordered advised by TEG? Just because I think you mentioned 80 packed red blood cells with just 5 FFP components.
So they were using the TEG machine in terms of the FFP and cryo and octoplas usage. They didn't use much of them because they were using a lot of fibrinogen concentrates. I don't know what actually was used in terms of that because unusually blood bank at the Hallamshire doesn't issue those kind of products. They're issued by pharmacy. But I do know that when they ordered the cryoprecipitate, that was when they'd run out of fibrinogen concentrate. So I think that was quite late in the afternoon as well. So they'd obviously used quite a lot of other products before they got to the plasma products that they actually needed from us.
Okay.
There's a question on how common is this condition?
We probably see one a year, maybe, if that. So Percreta is normally the rarer of the complications, and a lot of the time the ones that I've seen in the past have only ever sort of attached themselves to the bladder, which is bad enough, but that's been a much cleaner kind of operation and the patient has survived. We see a few placenta accretas, but again, these are diagnosed quite early. And again, they're much simpler compared to this one, kind of surgical procedure. So the majority of time, the patients survive this procedure. So it's not kind of as terrifying. It's just this particular one had extended so far and was so vascular with the varices and the varicose veins spotted and things like that. That's why it was such a vascular procedure.
Great, thanks. So somebody said, they mean 5 doses equals 5 times 3 adult dose is 15 units of FFP. Harley, also, did you want to come in and ask this question? Give us a bit more background. Sorry, it's disappearing.
So if I've said sort of 5 doses of FFP, each dose is 3 bags of FFP. Or if I've said 3 doses of cryo, that will actually mean 6 physical bags of cryo, because 2 bags of cryo are 1 adult therapeutic dose.
I hope this answers your question, Harley. And then somebody's asking, were pharmacy informed of the MOH and prepared to order extra stock of fibrinogen concentrate?
I think they had notified pharmacy, but if they had, it will have only been 24 hours notice, same as the blood bank got. So I don't know how quickly or how much time pharmacy need to reorder products, to be honest. But yeah, I think they were notified, but because the patient deteriorated so quickly, it was like less than 24 hours notice.
So if you intend getting blood track later, this case can help you business case proposal. You can give it as an example on your risk register. A lot of time on paper traceability, including that work around with stickers. Good that you have 100% traceability. Thank you.
Yes, we love a blood track system.
Yeah, thank you so much. Great talk. Excellent work on presentation. How many people have you in your team in the lab? Best wishes. So this is a question from our colleagues in Bosnia and Herzegovina. So they would just like to know how we operate here.
Okay, so on any kind of good given day, we normally have at least 4 qualified members of staff, so 4 qualified biomedical scientists, which we did have on that day. And it took all 4 of us to deal with this particular case. We also drafted in another 3 qualified members of staff to help with the routine work and to make sure that people could go for tea breaks, lunch breaks, that kind of thing. And then we also have 2 dedicated we have 2 dedicated blood bank MLA staff who know all about traceability, how to sign out products, how to book products in. They really are part of our team as well. So on this particular day, we probably had about 8 or 9 members of staff working on it the whole time and doing the routine work. It's not the kind of case that would pop up at 3 o'clock in the morning, like a sort of I say normal MOH. Sometimes MOHs can occur when you're working on your own on a night shift, but I think because this one was so well monitored up until the patient became ill, there was no way this would have happened sort of at 2 o'clock in the morning when it was just one person on their own. They would have had to phone the staff in to help them with this situation.
So a couple of people are asking, were the extra staff already in work, or did they come from home, or did you have to pull them from other departments?
So we had to pull them from other haematology departments. So at the Hallamshire Hospital, we've got some specialised areas. So we've got a hemolysis department, we've got the routine haematology department, and an area called cell markers that work with white cells. And in each of those departments, we have staff that rotate into blood bank on the shift rotation. So basically, we told everybody else who was stealing their staff and tough. So we pinched staff from other areas, but the other areas aren't quite as acute as this situation was.
Great, thank you. Any other questions from anyone? Do you believe the patient could have survived if the situation was handled differently?
I don't think it could. I think the way that the patient's diagnosis progressed, if they'd have operated sooner, then there was a harm for the baby not being fully developed. So obviously they were trying to make a judgment there. Like I said, having read the post-operative notes, it sounds like the team did absolutely everything they could, and had they operated sooner, there might have been harm to the baby. So it was an obstetric and a family decision to go forward in this way, I do believe. So I'm not sure that anything could have had a better outcome, unfortunately.
Great, thank you. Oh, somebody's asking, was the baby okay?
The baby was fine. Yep, healthy baby girl. She went home with dad and 2 siblings. So yeah, and apparently they're still doing well.
Oh, that's great to hear. Any other questions before we close? One more question. It's coming.
I think it might be coming through post.
Yes. Great presentation. Any other questions in regards to this group or the presentation, or anything you want to ask about your certificates or about the feedback, anything at all? So one more question came by post. What was the patient's chances of survival? Was it 50-50?
I'm not entirely sure. I think that would be down to the obstetric team. I think there must have been a decent chance of survival. Otherwise, they wouldn't have operated. They wouldn't have attempted this surgery. So obviously, everyone thought that there would have been a good outcome. I think they just could not stop the bleeding. And rather than the patient lose so much blood and pass away under anaesthetic, that's when they made the decision, after speaking, I think, to the patient's partner, that she did want to meet her daughter if at all possible. So yes, I don't think they could have done anything else. They did absolutely everything that they could have done.
Great, thanks. So Anas will put in the link for the feedback. We do ask you to complete that after, like I mentioned earlier, after the talk, rather than before, because we do monitor the feedback. We do try to do what you ask us in the feedback. Also, all the presentations will be on our JPAC website under London region in education. We will be uploading the recorded session on the Patient Blood Management England YouTube channel. So don't know when, but it will be there, and we'll also put a link on JPAC so you can have direct access to YouTube. Then somebody says, you were lucky that they were all pause. sorry, it's gone. You were lucky that they were all positive. Have thought what your blood choices would have been had they been O neg.
Yeah, that would have been a much more difficult situation to manage. I think if that had have been the case, we would have definitely had to liaise with NHS BT and with our local Northern General Hospital and discuss what in fairness, we probably would have discussed it with the NHS BT consultants as well and said, what is the situation here? Because I think we would have probably switched to OD positive, especially in this case, the patient was due to have a hysterectomy anyway. So any chance of alloimmunisation, in fairness, you want the patient to survive first and then worry about the alloimmunisation afterwards. So we probably would have just switched straight to RHD positive blood in this situation.
And then somebody said Placenta Percreta has a 7% mortality rate according to WHEC.
Okay.
And then somebody said, what a great presentation. Thank you for sharing your experience. What a sad situation, but great news that baby and family are still doing well. Thank you again. Yeah, everybody seemed to have loved your presentation, so well done.
Well, thank you everybody for listening.
Yeah, thanks very much.